the upper extremity this morning, and next week we start going into the chest cavity. So we get into viscera, and that's going to be fun. So, thanks for dealing with the undergraduates yesterday. That was nice. So if we look at forearm, wrist, and hand, a little topographic anatomy here. Just look at the wrist. There's right there, you can see in most people, there's if you just do your fingers like that, a little tendon pops up. That's a very superficial tendon called Palmaris Longus. Some people don't have that tendon, or that little muscle. A significant number of people don't have it. So if you're missing it, don't be alarmed. Some people will have it on one side, not the other. So that's a pretty useful little marker. If you contract your wrist and radially deviate it towards the radial side, you can and contract it here. If you want to flex it, you can feel a tendon moving right there. That's called your flexor carpi, because it's the wrist, radialis. And right lateral to that tendon, immediately lateral to that tendon, is the pulse of the radial artery. Sure, right?
Yeah, I know that middle one.
It's not the middle one.
No, I know. I don't
It's the
have
carpal tendon. Okay, on the other side, there's a flexor carpi ulnaris. It's less prominent, but you can still feel it right there. And then just medial to that tendon is the pulse of the ulnar artery. You can feel that. So being able to test or to palpate the radial and ulnar arteries is something you're going to be doing part of your physical exam. You can see they label the tendons and the location of the arteries in this illustration. Special thing about the thumb, when we talk about range of motion, we all know flexion, extension, abduction, adduction, circumduction, that sort of thing. The thumb is a little unique in that it really does a whole bizarre range of motion. So this illustration up here just gives you the different movements of the thumb. Abduction is out of the plane of the palm, like that. Adduction is you bring it back. So there are abductors of the thumb, and there are adductors of the thumb you're going to find in the lab. We're going to talk about it here. Of course, extension is this way, and then flexion is across your MP joints, your metacarpal phalangeal joints, your MP joints, like that. Opposition is where you bring it across towards your little finger, and you can touch your little. Who was that? Was that you?
It's a cat.
It's a cat.
I will buy somebody a Coke out of that machine if they just walk up behind her one day, they'll squeeze her and to hear what comes out. You can squeeze her any way you want to, just to see what comes out. And then, of course, when you put the thumb back where it's supposed to be, that's just repositioning. The osteology of the wrist and hand, since we've been down to the forearm bones, there are 8 carpal bones, and they're arranged in 2 rows, a proximal row and a distal row. And there are tons of acronyms or mnemonic devices to learn the names. I always start right here on the thumb side, on the bone that's adjacent to the radius. Because that bone right there takes a lot of the compression. You know, when you put your hand down, that bone takes a lot of the weight. And that bone would be the scaphoid right here. It's also called the navicular, but scaphoid is the term that's most often used. when you go across the proximal row, next to the scaphoid is the lunate. I'll talk about scaphoid fractures here later on, but the lunate is another important carpal bone because you can dislocate the lunate. I've never personally seen one, but I mean, I've seen a bunch of fractures of the carpal bones, but not a dislocated lunate, but there is, that's out there. Next to the lunate is the triquetrum. I've never known anything to happen with the triquetrum. Sitting on top of the triquetrum, though, is the pisiform bone. So if you take your finger and you put on this bony prominence right here at the base of your hand, not the styloid process on the other side, but the base of your palm. You feel that right there? That little, that's the pisiform bone. And then if you continue to the distal row, the first one you run into is the hamate. The hamate has a prominent hook on it, called the hook of the hamate, so it's impossible to miss. Okay, next to that is the capitate. So there's the hamate. The capitate is right here. It's not labeled on this slide. There it is, right here. There's the hamate, capitate. And then the last two here are the triquetrum, the trapezium and the trapezoid. And I do the, I remember which one's which by the alphabet. Trapezoid comes before trapezium, I think. At least that's the way I remembered it in my head. I may be wrong.
It doesn't.
It doesn't?
No.
You know, it's kind of interesting because my whole life I've never actually looked at it. See, I just remember when I was a student, I said, oh, the Z comes last. So trapezium is last. But it's also... I've never... Anyway, that's how I know. You can also have injury to the capitate. It's rare, but it can also happen. But really the scaphoid and the lunate are the two biggest ones that you'll see. Going distally, you have 5 metacarpal bones. You need to understand the structure of a metacarpal bone. There's a base here, and then there's the shaft of the bone, and then there's the head out here. So if I say there's a fracture through the head of the metacarpal, you need to know it's on the distal part and not the proximal part. The base is towards the carpal bones. Beyond that, beyond the metacarpal bones, you have the phalanges. And you have, on the medial 4 digits, you have 3 phalanges. A proximal, a middle, and a distal phalanx. The thumb only has 2 phalanges, a proximal and a distal. So the way you describe these joints here, right here would be the MP joints, metacarpal phalangeal joints. That would be your wave bye-bye type of thing. And then you have the proximal interphalangeal joints, or the PIPs, of the 4 medial digits. And then the distal interphalangeal joints, the DIPs, up here. The thumb, since it only has 1 joint, is called the IP, the interphalangeal joint. I was looking at this last night, and there's a mistake on this slide, right here where it says head of middle phalanx and head of proximal phalanx. That's reversed. This is the proximal phalanx, so it's mislabeled. There's another thing that's mislabeled I found last night, and I'll see if I can remember what it was. Any questions on the osteology? this is just an illustration to the point that I made yesterday about the radius articulating over the ulna. If you on say who's Ryan, what number of cadaver are you?
4.
4.
There you go.
It's that one. We did an elbow yesterday, and we also did a shoulder. So you can take the elbow and pronate and supinate, and you can see where these bones are starting to roll over each other. Arterial supply of the forearm. We left off yesterday here with the common interosseous off of the ulna. So you got the ulna and the radial artery. As it travels down towards the wrist, the radial artery, we'll focus on that in just a second. The radial artery splits into a superficial and deep branch. You see right there, there's a superficial branch. There's a superficial and deep branch. I'll just say that. You can see it in better illustration. The deep branch, as the radial artery comes down like this, the deep branch will wrap around the thumb. The superficial branch just goes right into the palm. The ulnar artery also has a superficial and deep branch, but they both occur in the palm. These superficial and deep branches from both of these join in the palm right about here, in the mid-palm, as the palmar arches. So you have two arches here in the palm. You also have an arch on the dorsal side that you don't need to worry about. But you do need to see a palmar arch. The superficial arch is really superficial. Once you get through the palmar fascia, once you remove that, the superficial arch is actually pretty superficial. The deep arch is down there next to the bones. It's way down there. Now, coming off of the superficial and deep arch are going to be the metacarpal arteries and then the digital arteries off of that. I'll go into more detail here in just a little bit on that. If we look at the vascular, the course of the arteries, we found it yesterday beside the head of the biceps. It goes under the aponeurosis. The radial artery stays quite superficial, coming down the forearm. The ulnar artery takes a more deeper course through these flexor muscles here. You definitely ought to be able to tell these apart on the lab, because you'll probably see them again. The medial nerve, the median nerve runs right beside the artery, as I mentioned yesterday. On the other side, if you just take this muscle, this long muscle right here, it's called brachioradialis. That's the muscle. If you turn your hand like this and pull up against, you can feel the brachioradialis from up here extending down into the forearm. So it runs from the humerus all the way into the radial bone, radius. Pull that aside, just move it laterally, and you'll see quite nicely the radial nerve. The radial nerve comes out as the posterior trunk, the posterior cord, right? It wraps around we know it wraps around the humerus, the mid-shaft of the humerus, in the radial groove, and then gets in that space between the brachioradialis, and that's the easiest place to find it right there. If you go back and look at the metacarpal and digital branches, they have tons and tons of names, and I never remember these names. I hate these names. Who came up with these names? They're stupid. Dorsal metacarpal, let's see here, common proper digital, it's just stupid. It's just stupid. You know, if you just tell me it's a dang finger artery, I'll be happy. The thing I want you to know about this is off of the superficial and deep arch, you have metacarpal branches. Off of the metacarpal branches, you're going to have digital branches. I don't care that you know that it's called a common proper digital artery. Just know that they're digital branches. And they run down on either side of the finger. They run down on either side of the finger, and it's all fingers. And if you actually look at them, each digit has 4 arteries running down it. From the dorsal surface and the ventral surface, the palmar surface, there are 4 arteries that run down there. 2 of them are much larger than the other 2. The ventral ones are much larger. But don't go and memorize these silly little branches. I've underlined them because years ago I was a little bit more of a hard ass and I made people do it. But, you know, really, who cares? Nobody's going to say, what is, you know, is this a proper, you know, nobody's going to do that. Unless you go to work for a hand surgeon. Any questions about that? One thing, though, that you do need to know about is those 2 arches, superficial and deep, whether or not they are intact. Some people they don't communicate. And some people, they don't communicate. And so if you're going to draw an arterial blood gas, which is what you do with people in cardiac arrest or respiratory compromise, you draw a blood gas and you send it down to the lab and you get different values for the pH of the blood, the amount of CO2, O2, and bicarb. You'll have a whole class on arterial blood gases. And, these are critical things you need to know because you operate within a very narrow range of pH, and so things that alter pH are important clinically. So to get the blood, you get it from the arterial side, not the venous side. And the best place to get the blood is the radial artery. So this is, when somebody tells you to draw an ABG, this is what you're going to be doing. Now you can also get it from the femoral artery, but it's deeper. Radial artery is the way you do it. You take essentially a 1 cc syringe, has a needle on it, feel for the pulse, and you put it in the radial artery. You just stick it into the radial artery. The pressure alone will fill the syringe. It'll push the plunger up. You take once you finish with it, you take it out and seal it, put it on ice, send it immediately down to the lab, and then you put pressure on the artery for at least 5 minutes. You know, when you do a venipuncture, within 30 seconds, it's clotted off. The artery, though, you have to put direct pressure on it for at least 5 minutes. But before you do an ABG, what you want to do is a thing called Allen's test. And so, I'm looking for, you're kind of darkish. Okay, so, because it shows up better. Turn your hand that way a little bit. So what you do is you compress both the radial and ulnar artery. Now, what I want you to do is, hang on a second, let me, all right, do it. Keep going. Come on, a little brisker. All right, so open your hand up. So you see it's blanched, it should be blanched. So if I let go of the ulnar artery, it should pink back up all the way across, right? Okay, do it again. Open it wide up. And let go of the radial artery, it should pink back up again, right? That means she has both arteries supply the whole, all the hand. If you see up there on the screen, on the x-ray, the angiogram, the radial and ulnar arteries don't, these arches don't meet. So with this person right here, let go of the ulnar artery only supplies this part of the hand. It doesn't supply this part of the hand. So that means if you stuck the radial artery and you messed it up, you wound up with a clot in the radial artery or something because you're poking a needle in it, then this side of the hand will become ischemic because there's no blood flow. So always do an Allen's test before you do an ABG. All right, so the muscles of the forearm, and there are a bunch of muscles in the forearm, both the flexor and extensor surfaces. This is what you're going to need to do this weekend. You're going to need to sit over there in that lab, and you're going to have to look at these muscles 1,000 times to get them straight in your head. And this is one of those examples of where you pick up a muscle and your partner says, it's this, and they pick up a muscle, back and forth, and then go to another cadaver to do it. What you want to do with these muscles is, once one is tagged, look at where it's coming from and where it's going to, because that'll give you the answer. I'm not going to put the limbs in some funky position. They're going to be laid out like this, or like this, to get the extensor surface. So it would be pretty straightforward. You just have to spend the time to learn all these muscles. And there are a bunch. If we look at the extensor surface of the forearm to start with, you'll see all the extensor muscles here. There's a superficial group and a deep group. The good thing about this is that they're all innervated by the radial nerve. There's another muscle here called the supinator. It's the one muscle that strongly supinates. It's also innervated by the radial nerve. If we look at the muscles on the extensor surface, the one that stands out is this one right here in the middle. That muscle is the Extensor Digitorum longus. Extensor Digitorum longus, and it goes down to the 4 fingers. When I say fingers, I'm not talking about the thumb, the 4 fingers, and we'll extend them. That's all it does. They go all the way to the tendons, go all the way to the end. Well, sort of. I'll explain that in just a minute. But they cause both the MP, the PIP, and the DIP to extend. The one that goes to the little finger, as you see right here, you can see the tendon in your back of your hand, is called the Extensor Digitorum minimi. So here's the digitorum, and then there's another one that goes to that part that goes to the little finger is Extensor Digitorum minimi. It's like that Austin Powers movie. I always think about that. Now there are 3 carpal extensors. There's the extensor carpi ulnaris, which is right here. And then there's extensor carpi radialis, but there's a longus and a brevis. Extensor carpi radialis, longus, and brevis. And one overlies the other. They're very easy to see in lab. So when you do, if I'm going to contract the extensor carpi ulnaris, then that means I'm going to extend and ulnar deviate the hand. On the radial side, it's the extensor carpi radialis, longus, brevis, extend and radially deviate. When you go through, also, you can see those muscles up there, and there's the tendon going down to the carpal bones right there. All right, now beneath those, you'll have these muscles here that go to the index finger and to the thumb. The one that goes to the index finger is called Extensor Indices. So when you remove the skin on the back of the hand, you're going to see 2 tendons going to your index finger. One is the Extensor Digitorum, the other is its own muscle called the Extensor Indices. you have three muscles that go to the three long muscles, three long tendons that go to the thumb. The most lateral one, no, excuse me, the most medial one, the first one you get to is called Extensor pollicis longus. That's that tendon right there. Goes all the way out to the end of the thumb. The muscle bellies for these three muscles, by the way, are under Extensor Digitorum. The next muscle, next tendon you're going to get to is Extensor pollicis brevis. It only goes to the end of the proximal phalanx. So the brevis will extend the MP joint only. It's the longest that extends the IP. See what I mean? And then most really lateral, this one right here is called the Abductor pollicis longus. Think about this, where it is. It's right here. You can see the tendon. There's the tendon right there. If I'm going to, what is abduction? Abduction is that, right? To do that, I want to pull the thumb that way. And that's what that muscle is perfectly aligned to do. If you do that, if you adduct the thumb, you can feel that tendon tighten up. Okay? So those three muscles, they're deep muscles, run the thumb. The final one in the deep group is back here, and I love this muscle. It's flat, it wraps around the bone, it's really a nice compact muscle. There's the supinator, and coming out of the supinator is the radial nerve. You can't miss it. All you got to do to find the supinator, and the supinator is going to do this. It's going to run from here to here. It's going to run from here to here. So when it contracts, it's going to pull the radius over. Yes, sir.
What muscles make up the anatomical snap box?
I'm going to get to that. It's those three tendons right there.
Okay.
To answer your question. Any other questions? These muscles are so easy to find, and they separate so easy. All you have to do is put your finger between them and just run it down, and as they separate. They're just so easy to find. You just need to keep them straight. Here they are in the deep compartment again. Extensor Indices, Extensor pollicis longus, and then Extensor pollicis brevis and Abductor pollicis longus together. So the Extensor pollicis longus, if you do your thumb like that, you see the tendons? Paul was talking about the anatomic snuff box. You probably all heard about it. That's between these tendons. So the tendon that runs by itself is the longest. That's this one up here on the top. The brevis and the abductor longus are on the bottom. All of these tendons in the hand, or going to the hand, these long tendons, have a sheath around them. And that sheath is like a balloon. It has a slightly fluid filled. And that sheath allows for the tendons to slide back and forth without causing friction with surrounding structures. So you have a ton of tendon sheaths in the dorsal surface of the hand. You have them in the ventral surface as well. A cyst of a tendon sheath can protrude as a ganglion. This is called a ganglion cyst. It's also called a synovial cyst. It is neither a ganglion or a synovium, but that's what it's called. And these things, these cystic structures can form in these tendon sheaths, mostly on the dorsum of the hand, but sometimes people will get them on the ventral surface. They're like herniations. They can, the more you use the tendon, the bigger these things get. And when you're, like if you're carpenters, if they're building a house, they'll get big. Between houses, they get smaller. So, I mean, they can, some of them will grow, will enlarge and stay that way. Most of the time, they're not bothersome, but sometimes they are painful. Anybody in here have one? Wow, 1, 2, 3, 4. That's a class full of freaks. Okay? So, there are different ways to get rid of these things. You can try sticking a needle in them and withdrawing the fluid, but it really doesn't work so well because most of it is more solid than fluid. I don't know how many times providers will call me and say, hey, I've stuck this thing and I can't get anything out of it. Can you come over and try to do it? No, I'm not going to try to do it because 90% of the time you fail at it. Yet people keep doing it. The only way to get rid of it definitively is to surgically remove it. In the old days, and you know this, most of you probably know this, the heaviest book in the house was the Bible, the family Bible. And so to treat it, people would put their hand on a hard surface like the kitchen table and take the family Bible and slam it down to pop it. And that's the treat. You know, that's one treatment for it. I wouldn't advise it.
What happens to the fluid or the mass inside of it?
It truly bursts.
Yeah.
And as long as it doesn't heal up, it won't fill back up.
Okay.
Yeah. The nerves of the hand, now we know from yesterday the dermatomes are 6, 7, and 8, right? 6, 7, and 8. That's C6, C7, C8. But actually the nerves, the named nerves going into the hand are very important. And you need to know those. You need to know this right here. You need to know this. I keep pointing back. You need to know this. All right, so here it is. If I draw a, well, can I have your pen? So, if I draw a line across the top of my fingers like that, and then on the bottom I draw a line halfway down this finger like that. Halfway down this finger, like that. These are the 3 nerves that supply the hand. This is the ulnar. This is the median. The median supplies the tips as well. But the rest of the back of the hand is the radial. Radial, not radial. So when you're testing sensation, you test the hypothenar eminence, which is the bulge here to the little finger, the thenar eminence, which is this bulge, and then the back of the hand. And that way you've got the 3 nerves. So if you have carpal tunnel syndrome, that I'll talk about later on, that's compression of the median nerve. The symptoms are these 3.5 fingers, 1, 2, 3.5. 1, 2, 3.5. If you have ulnar syndrome, ulnar compartment syndrome, it's this 1.5 fingers. Yes, ma'am.
For median, would it also be the fingertips on the front or no?
it gets the nails, essentially the nail.
Of all 5 fingers or just?
Yes, all 5.
All 5.
Yeah. If you look at this illustration right here, you can see there's the ulnar nerve, and there's the median nerve, and they split on the 4th digit right here. So the median nerve gets the lateral side, the ulnar nerve gets the medial side. Okay? And again, like the arteries, these things have all these really ridiculous names. Palmar digitals, proper palmar digitals. Why they call a finger nerve a palmar digital? Why don't you just drop the freaking palmar name and call it the digital nerve? I don't know. Any questions about that? This is very important that you remember this dermatomal pattern. If you look at a cross-section of the, well, let me go back. You have the dorsal nerves and the ventral nerves going into the digits. If you'll notice right away here, you see that aponeurosis right there? It's actually called the flexor retinaculum. I'll talk about it more here in just a little bit. The flexor retinaculum. What that does is it crosses right here. So you have all these tendons going underneath it. If you didn't have that retinaculum, if I did that, all the tendons would pull forward, right? So they would be more in a line like this. The purpose of that retinaculum is to give you a better mechanical advantage by keeping all the tendons underneath it. If you'll notice on this slide, on this picture right here, the ulnar nerve is superficial to that retinaculum. The median nerve goes underneath it. Ulnar nerve is superficial, median goes under. So if you cut your wrist right here, the ulnar nerve is really superficial. You want to watch out for lacerations in this part of the hand or the wrist. And by the way, anytime somebody has a laceration, you always want to check 4 things. You want to check for range of motion. You want to check for strength, which tells you that the innervation is intact. You want to confirm that with sensation. You want to check sensation, distal to the laceration. And you want to check the blood supply. So range of motion, strength, sensation, and vasculature. And keep that in mind. Anytime somebody comes in with a complaint of, say, knee pain, or any issue related to the limb, check those 4 things always.
Doc, as far as blood supply, I know we talked about Allen's, but what if it's more superior? Like, how are you going to test that?
Well, so if she has a laceration somewhere, if I want to confirm that she has a good blood supply let me get you your choker. If I want to confirm that she has a good blood supply to the most distal part, I squeeze on a fingernail and let it go. Remember the first day? Capillary refill. Less than 2 seconds. That's what you do. Okay?
So you just check the most distal?
I'm checking the most distal. Okay. Kind of rolling along here, that's good. If you look at a cross-section of the digit here, this is the dorsal surface, there's the palmar side. You see the 2 big nerves there and the 2 big arteries. Smaller arteries are out here, the nerves on, I can never find the nerves in there. But the thing you have to, let me tell you here, is if you look on this panel here, remember I said the median is going to get the tops here? Actually, this 1.5 finger is the ulnar. Maybe I might have misunderstood your question earlier. The pattern, the 3.5 fingers, 1.5 fingers, is maintained on the top. So the ulnar gets this finger and half of that one. The median gets these. The point I want to make here is you see that the bottom, the palmar nerves go all the way to the end. In fact, there's a branch from the bottom that goes up to the top. That's why you get it like that. The dorsal nerves, meaning the radial, they don't go all the way to the end. You see, they stop right there. So the radial nerve is going to stop right there. The point I want to make about that is that if you've got the finger here, and you're going to take off this nail, the innervation of the nail is coming from down here, not up here. So when you do your digital block, you stick your anesthetic into here. The bottom of the finger is where you want to dump most of that lidocaine. Not the top, because the nerve doesn't reach it. This section right here illustrates a couple of points. One is, this is the Palmaris Longus. It terminates in the what's called the palmar aponeurosis. The palmar aponeurosis is very tough. Very tough. You'll have to take the scalpel to remove it. Don't even try to get through it with scissors. The other point here is that the median nerve goes deep to the flexor retinaculum. The ulnar artery and the ulnar nerve are superficial to it. Palmaris longus is also superficial to it. But all of the other tendons, arteries, and whatnot run under that flexor retinaculum. Under the flexor retinaculum is the carpal tunnel. If you have inflammation in the carpal tunnel from repetitive, mostly due to repetitive motion injuries like typing, you wind up with paresthesias of the median nerve. So people will come in complaining of, as I sit here and typing all day in class, I get numbness in these 3.5 fingers. Now when they say numbness in their fingers, you have to drill down and say, tell me exactly where you feel the numbness. And even give them a pen to draw it. If it's true carpal tunnel syndrome, they will have numbness on this side of the finger, but not on that side. Another nerve I want you to see, and they're probably all gone, judging by the, when you removed the skin yesterday, this is a very superficial nerve. The radial, here's the median nerve right here. There's a little branch that comes off of that called the median recurrent nerve. That median recurrent nerve provides the motor innervation to the 3 muscles of the thenar eminence. And unlike most every other nerve of the body, that reaches the muscle from the underside or the deep surface. This muscle actually crosses over the flexor pollicis brevis, which is that little muscle right there, to supply the three muscles, meaning that it's very superficial. So a laceration of the thenar eminence, you have to check these three muscles, and I'll go into them a little bit later on, by doing what? Testing range of motion, strength, and sensation. It's a motor nerve, but sensation of the thumb as well as the vasculature. If you suture that laceration and they cut that nerve and they lose function of the thumb, that's 100% disabled in that extremity. If you lose your thumb. Okay. Now, let's get to the muscles. No, let's take a break, and then we'll get to the muscles on the flexor side.
Zoom writing, but I just use like that. I don't use it. Oh, no. I didn't bring my computer today. Yeah, yeah, so I got this new
I know, I don't know if you liked it or not. I was gonna ask you. I don't know where you guys are. I haven't same questions, kind of like what the tests are. You can get it from Amazon. I haven't used it that much. I will use it for the first test, but I'd like to try it like Did you use it?
Yes, that was. So yeah, my like myself is that.
I want to take a picture. Oh, here. Yeah, I did
I think we originally
Okay, well, our one is
oh yeah.
and I think even some of the brachial I like the basic now.
I don't recall this.
I saw it before the next
I really like
How did you do it?
How do you know like what slide you're on?
for some reason it's making me like more
I don't know.
like this.
Like you can make it look
Well, I wanted to
that's
start
cool.
That's right.
I did a notebook.
Because 16, it gets five to go through the super.
And there's 42.
I set it up. Super cheap on Amazon.
Or even like.
I was just thinking that you would become some membranes.
I don't know, like you can create a notebook, and then you can do like cover and no cover.
How do you do that?
Whatever sense it was in.
Oh, I can't do it with mine.
Last time there stuff, they're all big.
And now it's like, here's Venus. Oh, but don't forget.
Yeah.
I think you have one.
And it's also a ton of like
You would
random
import it above.
physiology.
Yeah, I don't do that for anything. I did do this one, but that one was bad.
It wouldn't let us show all the books.
Like, it was kind of pointless, so I just didn't. And then I categorized it, like categories.
Yeah, I did.
I was scared to do that.
I said block keeper.
Yeah, I name all those by the thing, and then I make separate categories. Yeah, so I have to put all this stuff.
Okay, let's move on here. Onto the flexor surface. It's a little more complicated than the extensor surface. There are more muscles to deal with. The first one that you see in this illustration to the, over here, the far left, is the brachioradialis. The brachioradialis is innervated by the radial nerve. It's the only flexor of the elbow that's innervated by the radial nerve. The radial nerve otherwise innervates all the extensors of the elbow, but the brachioradialis is a flexor. Next to it, up here by the elbow, you can see this muscle. This is the pronator teres. Can you excuse me just 1 second? Are you okay? Okay, I'll call you back. Bye. Pronator teres is right there. My wife is going to her, she had surgery, like a birthday back, so she was going to her follow-up appointment, and she texted me that she fell down. She said, I fell down the stairs. Why would you just say, I fell down the stairs? Like my arm is broken, or, I'm okay, or something, so. Pronator teres is that muscle. And then right beside, distal to the pronator is a large muscle mass called the Flexor Digitorum, that's here. This one right here is the Flexor Carpi Radialis. Flexor Carpi Radialis, that's the one with the radial artery beside it right there. And right beside it is the Flexor Digitorum Superficialis. And when you do this right here with your fingers, you can feel the superficialis contracting. It has a branch that goes down into, all the way to the end of the 4 fingers, not the thumb. So it will flex the MP joint, flex the PIP joint, and flex the DIP joint as well. Flexor Digitorum Superficialis. It's kind of funny, when you're in surgery and you have a mask on, if you have to sneeze, you don't turn your head to you're sterile. You don't turn your head to the side because it could go out the mask. You just have to sit there and sneeze into your mask. So if you got a boogery, now you're involved in a 4-hour orthopedic procedure. You got to sit there with this goo mask on for 4 hours. So you might might want to get these allergies under control. Saving your career. You'll see below it here the Palmaris Longus. Palmaris Longus, like the Anconius, is about worthless. When you sit there and contrast or compare the pencil-thick muscle belly of the Palmaris Longus with the massive muscle bellies of these flexors, it's like wine. Okay. Now these are the superficial muscles of the forearm. You can see them illustrated here again. When you remove the Flexor Digitorum Superficialis right there, oh, by the way, you also have a Flexor Carpal. When you remove the superficial Flexor Digitorum Superficialis, underneath it is going to be the Flexor Digitorum Profundus. The Superficialis is on top, the Profundus is below it. I made a mistake earlier when I told you the Superficialis goes all the way to the end. It actually goes to the middle phalanx. As the Superficialis tendon comes down, it splits and inserts into the middle phalanx. Right there, did you see there? So it flexes the MP joint and the PIP joint only. The Profundus tendon is deep to it. Here's the Profundus tendon here. That tendon comes down and travels through the split in the Superficialis to go to the distal phalanx. So what the Profundus tendon does is flex all three, MP, PIP, and DIP. So if you do this, like that, just the DIP, that's the Profundus tendon. And when I had you take the skin off all the way to the end of the fingers, I want you to see the Profundus tendon running through that split. Kind of neat mechanics there. Now there's some other muscles that you'll see down here. This one here, going to the thumb, is called the Flexor pollicis longus. So if there's a longus, there's a brevis somewhere. The Flexor pollicis brevis is that one right there, the little one that forms part of the thenar muscle. That's the one the median recurrent nerve goes over. Flexor pollicis brevis, Flexor pollicis longus. And while we're on the thenar muscles, in case it's not labeled somewhere else, that muscle there is called the Abductor pollicis brevis. Remember where the Abductor pollicis longus is? That's the one back here on the extensor surface. Right there. So the Abductor pollicis longus is one of these snuff box tendons. Abductor pollicis brevis is the second muscle of the thenar eminence. If I cut that Abductor pollicis brevis, and underneath it is another muscle called opponens pollicis. And that's the muscle that does the opposition. So those three muscles are supplied by the median recurrent nerve, which is off the median. That's where its name comes from. So the median nerve supplies the thenar eminence. In carpal tunnel syndrome, if not treated surgically, not only do you have paresthesias in these 3.5 fingers, you have muscle wasting and weakness of the thenar eminence, of the thumb. Strength. It's one of the things 4 things you're going to test, right? Yeah.
You're saying thenar?
Thenar, yeah, T-H